All right, guys, this is a new recorded lecture for 2024 for the cervical spine. Just starting off with a joke here. Giraffes have long cervical spines. So do you have a 14 by 117 inch image receptor? I'm a veterinarian. It does make sense that the doctor would like all of the cervical vertebrae on one image. How many vertebral bodies does a giraffe have in their neck? Well, the answer might surprise you. It's actually 7, same as us. It's just their vertebral bodies are quite a bit bigger than our cervical vertebral bodies. An average cervical vertebral body in a giraffe can be 10 inches tall, which is longer than our entire neck. Just one cervical vertebrae in a giraffe, 10 inches tall. Okay, so moving ahead, same format as always with our procedures lectures. So we're going to go into the anatomy. Because this is the first of the spine lectures, I will be going into like the general vertebrae structure with this cervical spine. So we will do specific cervical spine vertebrae structure. But we're also going to talk about the general structure of a vertebrae. There's some common components: the vertebral body, pedicles, lamina, spinous process, transverse process, those type of things. So all vertebral bodies have, all vertebrae have those components, but they look differently depending upon which region of the spine you're dealing with. So we'll start in the general sense, which kind of looks like a thoracic vertebrae, and then we'll descend down into the specific sense of the cervical vertebrae. Slightly different structure, some unique things about the cervical vertebrae that are different than your typical vertebrae. And then we have some specialized vertebrae. C1 and C2 are specialized, and they have a unique structure all their own. C1 does not have a vertebral body, and C2 has a extra protrusion out of its superior side of its vertebral body. It's called the dens or the odontoid. Okay. General radiation safety and protection practices should be able to shield. We'll also talk about the radiosensitivity of the thyroid gland. I think we mentioned this with the clavicle. Same consideration. Your thyroid gland is on the interior of your neck. It is a radiosensitive organ. If the person wishes to protect their thyroid gland because they have thyroid disease and they've been given instruction by a surgeon, you can do their projections PA rather than AP and reduce their overall dose to their thyroid gland because of the attenuation of the beam through the body. So, proper use of positioning aids. Typically, your patient's going to be standing for cervical spine, but not always. In the case of a trauma cervical spine, there will be not necessarily positioning aids, much more like a immobilization device. They should be in a collar and on a backboard until they've had the cervical spine CT scan. That's the modern standard of care to clear for a cervical spine fracture is a CT cervical spine. It used to be the plain radiograph series of 5, but now they've modernized it. Since I was a tech, I think it was like 3 or 4 years in, they changed it to the cervical spine CT is the standard. You get a negative cervical spine CT, and then you can remove the collar and the backboard. Okay. Proper use of positioning aids. You might be using 45-degree angle sponges for any table examinations. You should be using the table bucky and not tabletop. The exception to that rule would be trauma cervical obliques, which I'll teach you how to do. Okay. Simulations of exams. That's going to be next week. I'm recording this on February 5th. We just got done with physics this morning on thermodynamics, just for your frame of reference. So when I say next week, I mean the week following exam 3. Okay. Image critique, cervical spine images, we will also get to that hopefully next week. So we might have some reference images that I can name some anatomy here in the slides. Okay, your vertebral column is the central axis of the skeleton. Everything that comes more proximal. Eventually, you could trace the connections back to either the rib cage, which tethered to the skeleton, or the skeleton itself. So all the way through the pelvis, the wings of the pelvis tethered to the sacrum at the sacroiliac joint, and so the entire lower extremity is essentially tethered to the sacrum indirectly. Got a beeping sound going on overhead. It's very faint though. Oh, it might be a truck backing up in the loading dock. I apologize if you can hear that. It's distracted me a little bit. So that was in the pelvis. The sacroiliac joints basically indirectly tether the lower extremities to the bottom of the spine at the sacrum. In the thorax, the rib cage tethers directly to the thoracic vertebrae. The shoulder girdle hangs off of the rib cage, and so those are tethered to the spine, and then the head rests upon the atlas, which is C1. Okay. Sometimes you call them C1, C2. They're also called the atlas and the axis. Okay, and we'll get into that in a little bit. The spine is usually, for normal anatomy, centered to the posterior mid-sagittal plane, okay, in the posterior trunk of the body, so the thorax and abdomen, but it also extends into the neck, to the base of the skull for the cervical section. Okay. Now, what does the spine do? Well, it provides cushion and support for your trunk, so your entire rib cage hangs off the spine. So effectively, your lungs are supported by your rib cage. They're hanging off. All your internal organs are effectively hanging off the spine. The mesentery and the diaphragm tether to posterior abdominal walls, which tether to the spine. So the spine is basically like the cornerstone of your foundation. Okay. The skull rests its entire weight upon the top of the cervical spine. Your spinal cord is housed in the vertebral foramen of the spine, which is a vertical channel passing from one vertebral body to the next, above and below. Okay. And then most of your major muscle groups through your torso, I said most, tether back to the spine somehow. The rectus abdominis does not, but that's anterior. A lot of your major muscle groups, especially the ones in your back, tether to the spine. Your trapezius, your latissimus dorsi, your gluteus maximus, all those muscles tether back to the spine. Okay. So the vertebral column is broken into 5 regions or 5 groups, and it's according to basically what it really is, just the parts. Okay. So cervical means neck. So the cervical vertebrae are the bones in your neck. Thorax is the chest. The thoracic vertebrae are the 12 vertebrae of your chest and your rib cage. Lumbar, the lumbar is the region below the thoracic. Typically it's 5 lumbar vertebrae. Sacral is typically 5 fused sacral vertebrae, so they're all, there's no separation between the sacral vertebrae. Cervical, thoracic, and lumbar, all the vertebrae are separated by intervertebral discs. We'll get to the structures of those in the anatomy section. And then coccygeal vertebrae, this is actually your tailbone. It's remnants of our biological ancestors that may or may not have had tails. Okay, you'd have to go into biology and evolution to figure out when tails disappeared, but the coccyx is essentially the tail that we don't have. It's tailbone vertebrae of a tail we don't have. There's usually 3 to 5 segments also fused for the coccyx. Okay. Each segment of the vertebral column has a curve. It's kind of like a stack of S-shaped stack of books, such that it distributes. It's a weight distribution technique such that the bottom of the spine doesn't get crushed from the pressure of the head. So if you stack your vertebral bodies vertically, the L5-S1 is going to feel the weight of all of the vertebrae above it. But if you S-curve the vertebral bodies, then L5-S1 only supports the next 3 or 4 above it. And then when the thoracic bodies curve the other way, then those are supported differently. So it's a weight, it's a mechanism. The structure of the lordotic and kyphotic curves is to better or more evenly distribute the weight of the upper body onto the lower vertebral bodies. Okay, so your cervical and your lumbar region have a lordotic curve. That means it bows anteriorly. Your thoracic and your pelvic, that is your sacrum coccyx, those have a kyphotic curve. That means they bow posteriorly. Okay. Scoliosis is a pathology where you have abnormal lateral curvature of the spine. Your spine is not supposed to be laterally curved. Kyphosis is a condition of increased kyphotic curvature of the thoracic spine. It's often called hunchback. Okay. All right, your vertebrae, most of them are separated by intervertebral discs. The exception would be the sacrum and the coccyx. Those vertebral bodies are fused. There is no intervertebral discs. Okay, typically the intervertebral discs are very much like, not structurally, but functionally wise, it's like the meniscus of the knee. It's a pillow to provide support. And so, your spine functions as a big shock absorber too. Every time you take a step, every time you jump, every time you pick up something heavy, your spine collapses on itself just a little bit. You get a little bit shorter. But that cushioning is there to prevent, that from hurting too much. Okay, it absorbs some of that collapsing force that you experience. Okay, so here's our vertebral column. On the left is an anterior view. The blue is the intervertebral discs. And then the side view or the lateral view is on the right. And then you can see the lordotic curves in the cervical and lumbar region, and the kyphotic curves in the thoracic and the pelvic region. Okay. So, numbers of vertebrae. Cervical vertebrae, there are 7 in number typically. You can have a thoracic rib, that is, you can have, or a cervical rib rather. C7 can occasionally form a rib, just like Team 1 does. Okay, so you could have possibly 6 true cervical vertebrae and then have a cervical rib. It's a genetic variance. Thoracic vertebrae, there's supposed to be 12 of those. Those correspond to the 12 ribs that you have. That's how you distinguish typically thoracic ribs or thoracic spine vertebrae from cervical vertebrae is the thoracic bodies have ribs articulating with them. When the ribs terminate, that is L1, and there are 5 typically vertebral bodies to the lumbar spine. You can occasionally get a non-fused S1, which is sometimes referred to as an L6 vertebrae. That is also a genetic variance. Okay. Intervertebral frame. Well, we'll get into the piece parts here in a little bit. I just want you to, that's enough for this slide. All right, so our typical vertebrae, this looks most like a thoracic vertebrae. And so just pay attention to what the piece parts are called. So looking from the top down on the left, there's a big hole in the middle. That's the vertebral foramen. Okay? Do not confuse that with the inner vertebral foramen that we're going to learn in a little bit. The vertebral body is anterior. It's roughly shaped like an ice cube with rounded corners. Okay? Coming off of the vertebral body posteriorly, the first part of the arch is called the pedicle. The pedicle is a little stumpy bridge of bone. And then, so the pedicles come off the posterior corners of the vertebral body, and then they transition into lamina. The lamina fuse posteriorly to form the base of the spinous process. So going around the arch, you have pedicle on the left, lamina on the left, then you go past the spinous process, then you have lamina on the right, and then pedicle on the right, and then you're back around to the vertebral body. Typically, but not always, in between the transverse process, sometimes move forward to the area of the pedicle and the cervical vertebrae. The transverse process typically, though, are situated in between the lamina and the pedicle, but not always. From the side view, we're going to see that there's facets. There's superior articular facets, inferior articular processes. On a thoracic vertebrae, you also have those demifacets and a facet on the transverse process. Now, since these are all flat articular surfaces, you can expect that the superior articular process and the inferior articular process of the vertebrae above form a gliding joint between vertebral bodies, and you'd be right. So the intervertebral joints are gliding joints, and actually the correct word for those is zygapophyseal. Okay, we'll get to the spelling of that in a minute. Okay, so pedicles always project posteriorly from the vertebral body. Remember, the vertebrae is the body plus the arch. The body is the front part, the anterior part, shaped like an ice cube. So if I say the vertebral body, that means the ice cube part in front. But if I say the vertebrae, that includes the arch. Okay? So pay attention to that nuance. The bottom of the pedicle is concave. There's actually a part of a foramen there, and it forms the intervertebral foramen with the one below it. Okay, the vertebral notches are the intervertebral foramen. When they're stacked, you'll see they're intervertebral between vertebrae, hole in a bone between the vertebrae. Okay. Articulation of the vertebral notches forms the intervertebral foramina or foramen. Lamina project posteriorly and medially from the pedicles, and then the two lamina left and right fuse to form the spinous process in the most posterior portion of the vertebra. Okay? Your transverse processes typically project laterally. They always project laterally. That's why they're called transverse. Usually they're in between the lamina and the pedicles. For the cervical spine, they're actually going to be adjacent to the pedicles. Spinous processes project posteriorly and inferiorly from the junction of both lamina. Spina bifida is when the lamina fail to fuse. So you actually have an open vertebra posteriorly, and it usually comes with an open meningeal membrane, and the patient is leaking cerebral spinal fluid. Okay, it's a terrible congenital defect. Usually goes along with lower extremity paralysis. All right. 4 articular processes arrive from the junction of the pedicles and the lamina, 2 superior, 2 inferior. And they articulate with the vertebrae above and below, respectively. there's the spelling that you're looking for. Those form zygapophyseal joints. That's how you say that. Or interarticular facet joints. Okay? But the preferred term on my quiz questions are zygapophyseal joints. Okay? So for just the cervical vertebrae, that was typical vertebrae that we were talking about. Every vertebrae has lamina. Every vertebrae has pedicles. Well, I'll go back and clarify most. C1 is a really strange critter, but we'll get to that. Most vertebrae have pedicles. Most vertebrae have lamina. Most vertebrae have transverse process. All vertebrae have a vertebral foramen traveling vertically through them, and most have an intervertebral foramen traveling in the transverse plane, but not always. Okay. Bifid spinous processes. So in the cervical region, the spinous process actually bifurcates like a fish's tail. Okay. So it's got like two little knobs on it posteriorly. Instead of a singular process, it kind of divides in half and looks just like a fish's tail. Okay. Now, C1 and C2. Superior aspect of C1 is helpful because you can see where the odontoid goes, and it's the transverse atlantal ligament kind of pins the odontoid against the anterior arch, and then you get a nice pivot joint there. Okay, and so turning your head side to side like you're shaking no, you are actually pivoting your C1 with the dens, the odontoid, as the pivot point on C2. Okay. Now you might think that C2 kind of looks like a linebacker wearing shoulder pads. And that's what I saw when I first saw C2. And so that's just how I remember it. The shoulder pads are actually the facets of the superior articular process. And then the arms that are cut off are the inferior articular process. And those would articulate with C1 above and C3 below. Okay. The odontoid has a facet on its anterior surface to articulate with the anterior arch. Okay. So I mentioned previously C1 does not have a vertebral body. It's got two arches, anterior, posterior. It has lateral masses instead of true pedicles. It has a transverse process and a transverse foramen. Okay, and those are basically the piece parts of C1. It's kind of unique. It doesn't do what the other cervical vertebrae are doing. C2 is also unique in that it has a dens or an odontoid process. The rest of C2 basically looks the same as C3 through C7, which I think we're going to get to here in just a second. Yeah, C7 has a palpable landmark. We learned about that in Chapter 2. It's called the vertebral prominence. If you stick your hand in between your shoulders right now, in between your AC joints on the posterior side, you'll feel a bump there. That is the vertebral prominence. Okay. Here's your typical cervical vertebrae. So anything that's not C1 and C2 kind of looks like this. There's your fish's tail, bifid tips on the spinous process. We have really long lamina on the cervical spine, very, very extended. The vertebral foramen is roughly triangular with rounded corners in the middle. The pillars have both the superior articular process and the inferior articular process, and it's called an articular pillar. Okay, it's kind of like a lateral mass, but it's not the lateral mass. The lateral masses are only on C1. Okay, now this is where it gets tricky. You see the ring that kind of looks like almost like a starfish with a hole punched through it, or even a really weird shaped donut. That's the pedicle and transverse process complex. Okay, On the outer side of that ring, that bony ring, is the transverse process. But the inside corner of that ring is the pedicle. That's just really screwy to me. You just have to memorize that. The transverse foramen is in between the pedicle and the transverse process. And then we have a vertebral body anteriorly to wrap it all up and close the arch. Okay, so that was our anatomy review. I'm going to take a quick break and then I'll come back and do our general procedure guidelines. Thank you for that short break. So, when you're going to start a cervical spine procedure, we're going to do patient preparation. A lot of people like to wear jewelry in this region, earrings that dangle. It's sometimes stud earrings, especially on the lateral cervical view, can get in the way. Best practice is to remove all earrings. Necklaces are definitely in the way, and sometimes bra straps in the lateral projection, especially if the adjustment clip for the length of the bra strap is at the top of the shoulder. It's going to get in the way of C7 from a lateral perspective. So we've got to watch for all that. Best practice, remove all jewelry, earrings, necklaces, things of that nature. If the bra strap is in the way, perhaps they can take the bra strap down onto the shoulder or off of the shoulder to get a metal-free image. For the open mouth projection that I'm going to show you, we need to remove the dentures if those are removable. Any tongue rings should also be removed if the patient cooperates with that instruction. If not, you just have them stick their tongue out for the open mouth projection, and usually that will displace the tongue stud or the tongue ring to somewhere inferior to C1 and C2. Okay, that's about it for general patient preparation. Okay. Patient condition, or I'm sorry, patient position, most commonly is upright, but supine is warranted in case of trauma or in case of sometimes the geriatric folks sway a little bit side to side, and so you're introducing motion artifact. If you try to stand them up for a cervical spine, you might find it's just easier to lay them down for cervical spine x-ray. That being said, the lateral cervical spine x-ray should always be, you should always try to attempt it vertically. It just presents better, and it's a better x-ray if you make an attempt to do that one while the patient is standing up. Okay. IR collimated field size, 10 by 12 is sufficient for all cervical projections, including the swimmers. What? Yeah, 10 by 12, you heard me. Okay. SID is specialized for the lateral cervical spine. We want to use 72-inch SID. I don't know why that doesn't carry over to the swimmer's projection. Swimmer's projection is recommended at 40. All other views recommended at 40. I got to check on the obliques. Sometimes the obliques, they say 72 as well. Hang on just a second. Let me check the book. Yes, I was correct. For the lateral and the obliques, it's recommended you use a 60 to a 72-inch SID for those projections. All other projections, 40 inches is fine. ID markers, there is a difference between the patient's left and right side. Make sure you mark your images correctly. You're going to be doing left laterals, so you'll use your left marker for any lateral or swimmer's projection. Radiation protection, no reason not to shield anybody for this exam. The reproductive organs are well away from the anatomy of interest. It is no problem to apply a shield. The thyroid gland is radiosensitive, so if you have someone with thyroid issues and requests that you take precautions to reduce their dose to the thyroid gland. Switch all your AP views to PA views, and you'll do just fine. There is going to be motion artifact if you allow the patient to breathe during the exposures. Now, we do want that for the swimmer's projection. We can use a breathing technique, kind of like what we did, I think it was the sternum or maybe the transthoracic lateral, that a breathing technique was utilized or recommended. You can use a breathing technique for the swimmer's projection as well. All right, the Fuchs method, careful how you pronounce that, okay, is for the dens or the odontoid. It's contraindicated if cervical fracture is suspected. So you can't do a Fuchs method for trauma radiography because it involves aggressive manipulation of the tilt of the head, anterior to posterior. Okay, you got to raise the chin way up to get a Fuchs method. Okay. Only upper part of the dens is demonstrated, okay? And it for the Fuchs method, it is a pretty picture. The dens is superimposed over the foramen magnum, which is the hole in the occipital bone through which the spinal cord leaves the cranium. Okay, so here is your Fuchs method. You're going to have the patient supine or upright alternately, but this is much more stable. Okay, extend the chin until the tip is vertical. That is the lower jawline from the angle of the jaw in the back underneath the ear all the way to the tip of the chin is a vertical line. So the edge of their jaw is a vertical line. Direct the central ray to the mid-sagittal plane immediately below the tip of their chin, and you should be aiming at the odontoid of the dens of C2. Okay. And this is how it looks if you do it right. So on the bottom you see kind of looks like a single mountain peak on a curved surface. That's actually the odontoid bone, or the occipital bone, rather, odontoid bone. That's the occipital bone. That's the base of the patient's skull. At the top, you see like a canopy that's brighter white. That's the patient's mandible. The dark circle in the center is the foramen magnum. And then the little bone that looks like a tooth, that is the dens of C2. Okay. Now, the reason we do a Fuchs method is because, and then there's two triangles or turn signal indicators pointing straight at the dens on either side. Those are the lateral masses of C1. Okay, you can just barely see those joint spaces around those lateral masses. But the reason we do this is the dens is one of the sites of fracture. Now, I just got done telling you you can't do this if there is a fracture. So I've never seen a Fuchs method that was positive. That's because we don't do this one unless we're absolutely certain that the cervical vertebrae are not fractured, because it does involve a radical extension of the head. Okay. C1, C2 open mouth. This is our more routine projection to capture the dens and the lateral masses of C1. You are going to place the patient supine or upright, and then the upper incisors. What are those? Oh, those are the front teeth of the upper jaw. All right, so you have, patient has two rows of teeth, upper teeth coming out of the maxillary bone and the lower teeth coming out of the mandible. Okay, so it's the upper incisors. Incisors are the cutting teeth. That's how you eat carrots, with your front teeth. Okay, so the upper front teeth should line up with the mastoid tips. Now, where are your mastoid tips? Those are the bumps behind your ears. They're also the bumps behind the patient ears. So reach behind their ears, and it's going to be kind of like directly in back of their earlobes. You know, the little dangly things at the bottom where you pierce. Okay, about an inch posterior to that, you're going to feel bumps on either side of their head, right behind their ears. Okay, Wear gloves. People forget to wash back here. All right. Those bumps, those mastoid tips, have to be lined up with their front teeth in a vertical line. And then you have them open their mouth as wide as they can. And then you shoot the central ray directed to the center of their open mouth. And this is what you get if you do it perfectly, okay? So again, let's spot some of the structures. You can actually see the base of the skull. Remember how it was like this curved, there was a single mountain peak with a curve? That's actually right behind the dens, behind the very tip of the top of the dens, okay? Intersecting, the mountain peak is actually intersecting one of the front teeth, okay? So you see the teeth of the upper jaw in line with the base of the skull, perfectly superimposed, and the dens and the lateral masses right below that level. So right in the center of the exposure is the dens. The body of, the vertebral body of C2 is right below the dens. There's the shoulder pads of the linebacker. So you know that those are the superior articular facets there. Those articulate with those lateral masses. If you look really closely at the dens, you can see the anterior and posterior arches superimposing the dens. Okay, it's kind of a bone bridge that connects the lateral masses. One of them is magnified, one of them is not. Okay, you can also see the spinous process of C2. That is superimposed. That's immediately about 2 centimeters below the dens, superimposed over the center of the vertebral body of C2. Okay, and then you can see he's got some dental work done on his lower molars. He's had some fillings, so on and so forth. Okay, so the mandible, then moving up, you can see vertebral body and superimposed spinous process of C2. Then moving up, you can see the intervertebral disc space. Technically, it's not really a disc, but intervertebral joint space of C2 to C1. You can see the lateral masses of C1 in the middle. You can see the dens superimposed by the posterior and anterior arch. And then immediately above all that, you can see the base of the skull superimposed over the teeth. Okay. This is an incredibly difficult shot. Okay. You're talking about like those two objects that are superimposed, the base of the skull and the front teeth. Those objects are typically 8 inches apart. This tech got them right on top of each other. We're not even 1 degree out of rotation here. Okay, this is perfectly positioned. It is very difficult to perfectly position a C1, C2 open mouth. This is one of the more repeated views that technologists do, just because it's so hard to line up correctly. Even if you're just 1 degree off, either the front teeth obscure the dens or the base of the skull obscures the dens, with just 1 degree off from correct positioning. Our axial C-spine, hang on just a second. Our axial C-spine, done with the patient standing or sitting, laying down. They can also sit if they're very tall. We want to use a 15 to 20 degree cephalad angle to open up the intervertebral discs and present them at their true height. Okay? If you look at the lateral cervical spine in the book, you're going to see that the disc spaces run downhill from posterior to anterior. Shoulders should be in the same horizontal plane, that is, the patient should be square, true AP. Mid-sagittal plane aligned with the midline of the image receptor. C4 at the center of the image receptor, you also direct the central ray to C4. Mid-sagittal plane of the head perpendicular, so don't twist the head to the left or the right. Don't tip the head to the left or the right. Extend the chin to place the occlusal plane perpendicular to the tabletop or the vertical bucking. Now what the heck is the occlusal plane? That's the bite plane. So make them smile, okay? So you tip the chin up just slightly and you say, could you just smile for me with your teeth closed? Just give me a, kind of like you're wincing. and then you'll be able to see the occlusal plane, and you'll see if it's perpendicular to the image receptor. If it is, you're lined up to C4 with a 15 to 20 degree tube angle, opened up to 10 by 12 lengthwise, then you're ready to shoot this projection. And that's what it'll look like. Nice, tall. Right in the middle there, you can see the black stripes that are going horizontal. Those are intervertebral discs. And in between those, the ice cube shaped things, those are the vertebral bodies. Now, superimposed in the center, there's a couple structures there. First of all, there's an air-filled trachea, so that's good. Your patient's still breathing. There's also spinous processes, right? And those are kind of offset to the vertebral. They project a little bit low to the vertebral body that they correspond to. But you can see them right there in the middle, and they're centered to the vertebral bodies, which is a radiographic sign for rotation, okay? Now, how many cervical vertebrae will you actually capture here? You're only going to capture C7 to C3 if you're lucky, okay? You might actually clip part of C3. I've seen that happen. The way that that happens is you don't tip the head back either enough or you tip it back too much. If you don't tip it enough, the mandible gets in the way of C3, but if you tip it back too much, the occipital bone, the base of the skull, the back of your head gets in the way of C3. Now we can count these out. You can see the ribs coming off of the second one from the bottom. So that's got to be what? If it's got a rib coming off of it, isn't that T1? We're going to assume that cervical ribs don't exist. It's not a genetic variant. So we're going to call that T1. The next one up would be C7, then 6, then 5, then 4, then 3. And it looks like we're clipping. We got the bottom half of 2. This is an excellent radiograph, okay? Usually the shadow of the head, which is, see how it's impenetrable, it's bright white? That's because you've set the technique for going through a cervical spine, not going through a head, okay? And so the head partially superimposes C2, but we can see that on the odontoid shot, on the open mouth shot. So we really only need C3 through C7, and we have those captured here. And so this is a good radiograph. Okay. For our Grandy method, no one calls it the Grandy, they call it the lateral cervical spine. You'll be able to see the zygapophyseal joint spaces in between the pillars on the lateral cervical spine. Okay, we are going to use a 72-inch SID for this one. So the open mouth and the apiaxial are both 40 inches. And typically that's not the order. Typically the order is do the lateral first, because the lateral is most diagnostic as far as trauma, dislocation, displacement, subluxation, spondylolithasis, those type of things. If you don't know what those words mean, please review the pathology page in the Merrills for the spine chapter. Okay. Now we can actually count vertebral bodies here. We have an air-filled trachea, we have a hyoid bone, a larynx. Okay. Looks like the epiglottis is partially down. They might have been in the midst of swallowing while this radiograph was made, because it looks like the epiglottis is partially down. There is an air-filled trachea. You can see the cartilage ribs of the trachea down low there underneath the voice box. Now, but that's not the area. The soft tissue really isn't the area of interest. The area of interest is the vertebral bodies of the cervical spine. And so we want to be able to figure out if we got them all. Okay. And so at the top, right under the base of the skull, that first one is C1. And then the one that's bigger than it immediately underneath is C2, and then 3, and then 4, 5, 6. We have all of 7, and we have 3/4 of T1 at the very bottom. T1 is the one that's fading out to white right there about halfway through. So we do have all 7 cervical vertebrae, so we don't need a swimmer's. You add the swimmer's projection when you do not get all of C7T1 disc space. Okay, but it looks like we have it here. All right, so let me show you the parts going from anterior. We've got, of course, the pharynx and the trachea. Immediately posterior to that, you have the vertebral bodies. Okay, So those are those cube-shaped things. Well, near the bottom, they're cube-shaped. When you get up to C1 and C2, they're kind of irregular because those are special structures. Okay, so those are the vertebral bodies, and then the black spaces in between those are intervertebral discs. And then immediately posterior to that, you see some like black slanted lines with chunks of bone in between. Those are the pillars, the articular pillars, and the zygapophyseal joints. Okay, and so it goes vertebral bodies, zygapophyseal joints, and pillars, and then spinous processes from anterior to posterior. And that's what you can see on these lateral cervical. It's basically three parts. Okay. And they should have a smooth alignment. They should have a nice, smooth, natural lordotic curve. I can tell you we've got some spurring. It looks like at 4 or 5 anteriorly. There's a little bit of spurring. Doesn't look bad though. Got some good height. C71 is that disc space is a little bit more narrow than 6-7, so there might be some degenerative change at that disc, but I don't see nothing like crippling or anything. There's just some minor, the beginnings of arthritis and degenerative changes here. Okay, you can see the EAM, the external auditory meatus, superimposed left and right. About an inch above C1, and that's where I'm going to advise you cut the light field off, is just above the EAM, because the EAM is the structure of the ear. It's in the base of the skull, or real close to the base of the skull. So if you have the EAM in the light field, it's also on the mid-coronal plane, so it tells you where to center front to back. If you have the EAM in the light field, you definitely have C1. Okay, and if you're centered C4, you probably have T1 and T2, which we do have. We've got T1 and T2 here. We just can't see them. They're underpenetrated. All right. So upright supine, mid-coronal plane perpendicular to the image receptor. Remember, this is a lateral. Your mid-sagittal plane is parallel. Again, we're centering to C4. C4 is basically the halfway point between the EAM and the shoulder. Okay, so you know where the shoulder is. I mean, you can see it jutting out from the middle of the neck. Okay, the AC joint is what we mean by the shoulder. So halfway between the EAM and the AC joint is C4. Shoulders in the same horizontal plane, relaxed down. You can affix weights so long as there's no shoulder trauma, and that will give you another ½ inch of real estate. Might make the difference between having to shoot as swimmers and not. Raise the chin up. You want to get the back of the mandible, which is called the mandibular ramus, the vertical portion. If you raise the chin, that swings forward of C1 and C2. If the patient has their chin tucked, then it's going to partially superimpose the anterior of C1, C2. So raise the chin to move it out of the way of C1 and C2. Okay. Direct your central ray horizontally. You will need a swimmer's projection if you cannot see C7T1, and some people say the top third. I say the top half of T1. Okay, so if you can't, it's not even C7. You got to see part of T1 in order to make sure you don't need a swimmer's. Okay, flexion and extension views. First of all, don't do this on a trauma patient. Second of all, let the patient move. Okay, so just model it, just give them instructions for the extension view. That's raising the chin. What you're going to say is the doctor needs to see how far you can raise your chin up without pain. Okay, typically these are like 6 weeks post-surgery, and they're trying to assess range of motion. Okay, and what surgery affected range of motion. So they're going to raise their chin up, and then you're going to recenter to the new mid-coronal plane. Yeah, it will shift. Let's see, when they raise the chin up, typically it shifts posterior, and then you have to make them take a baby step back. For hyperflexion, they tuck the chin to the chest, okay, and usually the center shifts anterior when you do that motion, and then they have to take a baby step forward to recenter. All right, so there's your flexion extension views. Again, normally this is post-surgery, but it could be pre-surgery. It could be that this is the before picture. Then they're going to do a fusion, and then 6 weeks after the fusion, they're going to do this series again, see if the patient lost any range of motion. Okay, you would expect that the vertebral bodies that are fused would, that's what a fusion means, is they don't move relative to each other. So they are going to lose some range of motion with a fusion, but it's a good idea to evaluate that. So the neurosurgeon kind of weighs that as to how well the case went. Okay. Again, the standard is 7 vertebral bodies, but 6 will do for flexion extension, because you're going to get a standard lateral, like a neutral, no flexion, no extension. Okay, so if you only get 6, to repeat it again, but you don't have to do a cervical or a swimmer's with flexion extension. That's ridiculous. Okay. So again, 72 inch SID. Again, we're going to position the patient laterally, left shoulder against the board, elevate the chin just some, and then hyperextension, elevate the chin as far upward as possible with the head going as far back as possible. Hyperflexion, tuck the chin to the chest and keep it as close as possible. Okay? So those are your flexion extension views. You should never force the patient into those positions. You should just instruct them to do the best they can. Okay? For your AP axial obliques, this is where we'll see the intervertebral foramen. Now, remember, and you should construct a table for upcoming quizzes. Zygapophyseal joints for the cervical spine show up on the lateral projection. That's a quiz question. Intervertebral foramen show up on the AP oblique projection. Okay? It's the side away, this oblique away from the image receptor that we can actually see intervertebral foramen on. Okay. When you do one cervical oblique, you're always going to do the other one. So it's always LPO, RPO, or in the case of the PA, RAO, LAO. Okay. Here's our cervical obliques. We still want the tube angle 15 to 20 degrees cephalid because the disc spaces haven't really changed their orientation. Now that looks a little steep, a little steeper than 45, but you are going to put your patient at a 45-degree angle to the image receptor and the vertical bucci. Okay. Now if you want to, say this looks nothing like what I'm going to tell you. So everyone's seen a dollar bill, but have you really looked at a dollar bill? Specifically, the picture of the person on the dollar bill. I'm going to wait till that call. Okay. So if you look at George Washington on the dollar bill, he's in an oblique, he's in an AP oblique C-spine pose. Okay. Now you'll never forget how to pose. This is a little steep. This is more like 60 degrees of rotation. We want 45 degrees of rotation, chin elevated ever so slightly, 15 to 20 degree tube angle, 72 inch SID for these oblique C-spines. And you're going to do one, you're going to do the other. They're a set. Okay? This is what you're going to see, open intervertebral foramen. So you see those circular black rings right there, right basically to the side of the intervertebral disc. Yeah, those are the intervertebral foramen, and they show up at a 45-degree orientation to the mid-sagittal plane. Mandible brought forward, make sure that it does not superimpose the anterior aspect of C1, C2. Okay. For the PA axials, remember we said the side up intervertebral foramen shows up on the APs. It's the side down intervertebral foramen shows up on the PAs. So again, 45 degrees of rotation. Now we're going to reverse the direction of the tube angle, 15 to 20 degrees caudate, because we're going through PA rather than AP. Okay. And this one's nicer. Now, if you compare the two, if you go back and forth, what you might notice is the intervertebral foramen are actually magnified on the AP axial projection. They present as more normal in size, non-magnified. And there's good reason for that. We've reduced the OID by about 4 inches. So if these intervertebral foramens seem crisper and clearer with sharper edges and smaller, that's because we've minimized OID for this projection. So the PA axial obliques is actually a better quality image than the AP axial obliques. All right. So, did you get C17-1 on your lateral C-spine? Okay. If the answer to that is no, you have to do a swimmer's projection. Okay. This view is necessary when you don't get all 7 cervical vertebrae plus half of T1 on your lateral. You have to include this one if your lateral was not sufficient. Okay. And so swimmers, we're going to make them swim. One arm up, one arm down, like they're swimming in a pool. Nobody swims like that. What are you doing? Okay? You can do it upright. You can also do it supine, lateral, or recumbent. I've done both. Okay? The near side arm, the side closest to the image receptor, which is typically the left, is the arm that raises, that goes superior. Okay? I have seen an opposite swimmers when the left arm was injured and they couldn't raise it, and so we raised the right arm and we changed our tube angle radically to compensate for that, but it did not turn out well. Best practice is what you see right here. Closest side is elevated, furthest side is relaxed and or affixed to a weight, so that they're reaching for the floor. You're going to center to the midline of the image receptor, and then we're going to direct the central ray to the C17-1 inner space. And so that means the image receptor has to be lined up to the patient's AC joints. Okay, so before you start raising arms, just line up to their AC joint. The AC joint is roughly at the level of C17-1, and then start moving the arms out of the way after you've set your height. Okay? Arm closer to the IR should be elevated and also displaced anteriorly to the cervical region. The arm lower should be reaching toward the floor, that is posteriorly, but also reaching behind the patient's back, and so posteriorly and inferiorly. What this does is it moves the humeral heads from a superimposing perspective to opposite corners, anterior and posterior corners, okay? And allows more room to see C17-1 free of superimposition. Now the clavicles and the scapula are still, especially the clavicles, they're going to get in the way. It's not a perfect x-ray, it's the best we can do. Yeah, that's it. See that clavicle running right through? Now look, it runs right through the body of C7. Can we tell if C7 is fractured? Not on this one we can't. The elevated clavicle runs right through it. Okay, so I've got some indicators there. The topmost indicator looks like a spinous process. I would say that's coming off cervical vertebrae number 5. The middle indicator is the elevated side. Oh, the top indicator is actually the center of the humeral head for the elevated side arm. The middle indicator is the clavicle for the elevated side. Okay, and then the lower indicator is actually the clavicle for the away side. The clavicle. So if they got the left side against the board, the lowest indicator here is clavicle of the right side if the left side's against the board. Okay. Now, what do you need for successful swimmers? You need to see disc spaces if possible without superimposition, but more importantly, you need to see anterior alignment of the vertebral bodies. If the anterior alignment is not there, then most common cause is herniated disc. All right, we made it to the end, ladies and gentlemen. We are going to talk more in detail in the procedures demonstration next week regarding a lot of those views. We'll spend a lot of time practicing orthodontoids. I'm going to double check your positioning, make sure you're doing it right, okay? Because it is a learned skill that needs practice. A lot of the other ones, you'll pick them up, you'll practice them independently, but I do want you practicing the open mouth projection just because it's so difficult to position, okay? Radiation safety protection practices, we talked about shielding, we talked about the thyroid gland and turning the patient PA for routine projections. Proper use of positioning aids, you could use an angle sponge for those oblique cervical spines. Just watch out for artifacts, especially if you have a radiologist that can't stand artifacts. We will do practice on each other in a laboratory setting. And the next time we host image critique, hopefully we'll be talking about the cervical spine. All right, that's all for now. You guys have a good day.